Hello, everyone, and thank you all for joining us today. On behalf of the Radiologia Society of Rio de Janeiro and OCAD, I want to welcome and thank you all. My name is Aline Serfari, and I'm here with Dr. Hilary Humans, who coordinates and moderates this series with me. Our guest speakers are Dr. Jan Fritz, Dr. Paulo Elito, and Dr. Linda Probyn, and Dr. Taciani Cantarelli. Well, actually, this is a special session for me as I have the pleasure to have Dr. Taciani Cantarelli in person sitting right here next to me. I also want to let you all know that the Brazilian Congress of Radiology and Diagnostic Imaging will be held from October 8th to 12th in 100% online format. The presentations today will be recorded and available on demand on the OCAD website, which is ocadmsk.com, and on the YouTube channel of the Radiologia Society of Rio de Janeiro. If you want to join the OCAD community and see challenging cases almost every day, please consider registering on the OCAD website. The speakers today will present their cases, and at the end, we all have a Q&A session. We will have. And if you have questions at any time during the presentations, please put them in the chat box, and at the end, the speakers will respond to them. Just a reminder, attendees have not been given the permission to screen record any of these presentations, as they may contain material under copyright. Unauthorized recording, use, distribution, and sale of this material without permission from the speaker is illegal. We thank you for your understanding, and without further ado, I will kick off the session. So we have the pleasure of having here today Dr. Paulo Elito. He graduated from the University of São Paulo with a medical residency in radiology and a fellow in MSK imaging and intervention at Instituto de Radiologia, Hospital das Clínicas da Faculdade de Medicina da Universidade de São Paulo. He's an MSK radiologist at Sírio-Libanês and Hospital das Clínicas da Faculdade de Medicina da Universidade de São Paulo since 2014, currently coordinator of MSK radiology at the same university. He's a radiologist at Hospital Vila Nova Star since 2020. He's the co-author of book chapters, and he has several papers on MSK radiology, orthopedic imaging, and other areas, including imaging of the spine, neuromuscular disorders, and rheumatology. He's an active participant of the Sociedade Paulista de Radiologia, where he has coordinated the MSK group from 2017 to 2019. And he's a member of the Brazilian College of Radiology. With that, please, Paulo, share your screen.
Okay, thank you, Aline. And for me, it's a pleasure to participate. In fact, I'm very glad to be the first to present, because it wouldn't be easy after these other amazing, sensational persons that will also talk today. So I hope I'll be able to contribute with some things I've learned with this case. So let's get to it. So over the next 10 minutes, we're going to talk about a case of a male 29-year-old male that had an injury during a football match. He presented a knee injury with swelling that was difficult to examine, but the orthopedist said he had an insufficient ACL, anterior cruciate ligament. The first interesting thing about this case is that although this was in Brazil, when I say that he was playing football, he was actually playing football and not soccer. But this is not relevant to the case, but some fun fact. This patient was asked to do an MRI of the knee, of the left knee, because the orthopedist thought he had an ACL injury. So these cases with ACL injuries, MRI of ACL injuries, are usually to confirm the cruciate ligament injury, but mostly to evaluate other structures, including menisci, other ligaments, cartilage, and bone injuries. So let's get to the MRI. So this patient, we're going to look at sagittal T2 weighted with fast saturation images, where we can see sequential images from lateral to medial. We can clearly see the bone bruises in the lateral femoral condyle and posterior tibia. We can see a lot of posterior soft tissue edema. And here in the central part of the knee, we can see that the ACL is torn. The sagittal images are not usually the best to see, to evaluate the ACL, but this is clearly a completely ruptured ACL. But also we can see that the posterior capsule is abnormal, is thickened, irregular, and with edema and some soft tissue edema in the surrounding the posterior knee. As we go more medial, we can see that the medial meniscus has some peripheral injury in the meniscocapsular junction. So there is abnormality at the morphology of the medial meniscus, and also some edema and irregularity at the meniscocapsular junction. Some bone bruises in the medial tibia. And here you can see that the semimembranosus tendon is thickened and with abnormal signal, with a very high signal among its fibers, here in the red arrows. Some capsular and pericapsular edema. As we go more medial, we can see that there is a lot of capsular and pericapsular edema, and there is a rupture just posterior to the medial collateral ligament. There is a discontinuity at the posterior oblique ligament that I will explain more the anatomy in the next minutes. So the capsule and the posterior oblique ligament discontinuity. The same findings can be appreciated at the coronal images, where we can see the medial collateral ligament there is no discontinuity in the MCL. Some edema around it, but maybe just because there is a lot of soft tissue edema in this patient. The torn ACL. And here we can have a look at the posterior oblique ligament just posterior to the MCL, and there is this large discontinuity. And some soft tissue edema. And in the axial images, we can see the abnormal soft tissue edema. As we go from proximal to distal, we will pay attention to the semimembranosus tendon. There is thickening of this tendon and very abnormal signal among its fibers, some high signal among its fibers, suggesting that there is a strain in the semimembranosus tendon. When you look at the posterior medial knee, we can find the medial collateral ligament that is unremarkable, but posterior to it, there is this thickening and irregularity of the posterior oblique ligament that is just over here surrounding the posterior medial femoral condyle, and this irregularity in its fibers. The yellow arrow, the torn ACL. Some posterior capsule abnormalities, and the posterior oblique ligament here is irregular and thickened. So this whole posterior medial capsule and ligaments are abnormal in this patient. We'll talk more about those structures in the next slides. And some bone bruises. So the diagnosis in this case was an anterior cruciate ligament injury, a torn ACL with a combined posterior medial corner injury. There is a very interesting paper about the posterior medial corner. It's from 2015 in radiology, but in radiographics, published in radiographics. It's not that recent, but it's very interesting to discuss the anatomy of the posterior medial corner. This corner is composed by the posterior oblique ligament, the oblique popliteal ligament, the medial meniscus, especially its posterior horn, the semimembranosus tendon, and the posterior medial capsule. So this is schematics of an axial cross-sectional image of the posterior medial corner. So we look for the MCL, and just posterior to it, we have the posterior oblique ligament. In the posterior knee, we have the oblique popliteal ligament, and the semimembranosus tendon that is very important. Also, we have the posterior horn of the medial meniscus and the posterior capsule. The semimembranosus tendon has several expansions and insertions that may seem a little bit confusing, but we'll see that in imaging, we will evaluate mainly its anterior and direct insertions at the posterior and medial tibia. And we will also evaluate the tendon that is in the green arrow, and in some cases we can see the scapular attachments, like in this image from our case, where you can see the capsular attachment that is abnormal. So, but we'll mainly evaluate the direct insertion in the pink arrow and the medial anterior insertion in the yellow arrow, the tendon, and some cases some other insertions. In the coronal image, we can see this very nicely, the anterior insertion of the semimembranosus tendon just in the medial tibia. Sometimes it can be confused as a meniscal flap, but it's clearly continuate with the tendon itself, and maybe some other distal insertions in the purple arrow. And here you can see in the sagittal image the abnormal tendon and its normal insertion, direct insertion in the pink arrow. It's interesting to say that the semimembranosus direct insertion sometimes also inserts in the posterior coronary ligaments of the medial meniscus. So this is probably what caused this injury in this patient, this peripheric capsular ligamentar meniscal injury. Also, we evaluate the posterior oblique ligament that also may seem confusing, but it is the structure just posterior to the medial collateral ligament that originates near the adductor tubercle and inserts in the tibia, in the capsule, and in the posterior capsule. Its posterior margin blends with the posterior capsule, so we'll see just this thickening of the posterior medial capsule just posterior to the MCL, and this is what is seen in imaging. We look for the MCL, and the posterior oblique ligament is just posterior around the femoral condyle. And here in the coronal image, just posterior to the MCL, we can also appreciate the posterior oblique ligament. So this is the normal posterior oblique ligament, a thin, homogeneous, low signal structure. And this is our case. We look for the medial collateral ligament, and we see that just posterior, we have a rupture at the posterior oblique ligament that is also thickened, irregular, and this is a rupture. So we talk about the semimembranosus tendon, the posterior oblique ligament, and the oblique popliteal ligament. It's mostly inseparable from the posterior capsule, and we'll see a thin capsule structure at the posterior knee. So this is what we will mainly evaluate of the posterior medial corner.
Hey, Leon.
Hey, interesting feedback.
This is the posterior capsule and the popliteal oblique ligament in our case that are thickened, irregular, and with abnormal signal. So we have a posterior medial corner injury. So what is the posterior medial corner function? It prevents the tibial rotation, especially sternal rotation, and also valgus, especially with the extended knee. It also contributes to anterior and some posterior tibial stability. And the posterior meniscus breaks a posterior translation of the femoral condyle superior to the tibia. These injuries occur mainly in sports injuries, including football, and sometimes in other accidents, including vehicle accidents, and is frequently associated with other ligament injuries, including cruciate ligament injuries and medial collateral ligament injuries. And in the physical examination, we will see a widening of the medial space of the knee, and rotatory subluxation of the medial tibia. When it's injured, we may have an anteromedial rotational instability that will be described as excessive anterior translation of the medial tibial plateau with external rotation and opening of the medial joint space. So this is the AMRI, that is the instability related to the posterior medial corner injury. When you have an AMRI, we usually have posterior oblique ligament injury. In most cases, we have also a semimembranosus injury, and we may also have a peripheral meniscal detachment. When you have a posterior medial injury, posterior medial corner injury, we usually treat with surgery, especially because they're mostly combined with other anterior or posterior cruciate ligament injuries. When isolated, they may be treated conservatively. And the surgery is usually plication, advancement, or reconstruction of these structures. So the take-home messages of this case is always mind your surroundings. So always mind the peripheral structures of the knee, the posterior medial corner, the posterior lateral corner, the anterolateral corner. So these structures are very important because they may influence patient outcomes and morbidity. The posterior medial corner imaging, sometimes the anatomy may seem hard, but the imaging anatomy is not as hard as it looks. And the combined and symptomatic posterior medial corner injuries are important cause of morbidity, especially when combined with anterior cruciate ligament injuries. And they are very important to be evaluated in our knee MRIs. Thank you for your attention, everybody. Those are my contacts. Feel free to send me emails or contact me in Twitter. And thank you again, Aline, for the invitation.
Thank you, Paulo, for the excellent, beautiful case and excellent explanation and revision of the posterior medial corner of the knee. Thank you.
Okay. Hello, everybody. I'm Hilary Yeomans. It's my pleasure and honor to invite Dr. Linda Probyn, who's an associate professor and musculoskeletal radiologist at the University of Toronto. She's the past program director for diagnostic radiology there and is now the vice chair of education for the Department of Medical Imaging and the current chair of the Specialty Committee for Diagnostic Radiology at the Royal College of Physicians and Surgeons of Canada. She has interests in osteoporosis, arthritis, ultrasound, sports injuries, and trauma, as well as teaching and education, including all of ultrasound simulation. Dr. Probyn has published several scholarly articles and presents her work and teaches at many national and international conferences. Fun fact, Dr. Probyn and I have the same birthday on different years. I know, Linda, Paulo is a hard act to follow, but try to do your best. Okay, share your screen.
I will try. Thank you so much. Just going to share here. Thanks, Hilary, and thanks for inviting me to speak today. It's really great to see all of you. Can I just get I'm assuming you can see this. If you can't, then please tell me otherwise. But I'm going to go ahead and get started here. So this is a case of a 22-year-old man who fell skiing and complains of thumb pain and swelling. So x-rays were performed, as you can see here, and I'm just going to show you a magnified view here. So these x-rays were reported as soft tissue swelling at the MCP joint with a small avulsion fracture from the base of the proximal phalanx compatible with an ulnar collateral ligament avulsion injury. So I'll just show you those images again. And you can see here, that's the small fragment that was referred to in the report. So this patient was referred to plastic surgery for management, and the surgeons were concerned about a Stenner's lesion. So an MRI was performed. And here's the MRI. You can see the coronal and axial images. And what you can see here is that the ulnar collateral ligament is detached from the base of the proximal phalanx. And there's a thin, low signal intensity structure lying superficial to the ligament, which is the adductor aponeurosis. So this was reported as an ulnar collateral ligament avulsion injury, but there was no Stenner's lesion. So we're just going to focus the discussion now on the ulnar collateral ligament, and I'm going to talk about the anatomy here. You can see the ulnar collateral ligament extends from the head of the metacarpal to the base of the proximal phalanx at the thumb. They're the adductor muscles that has an aponeurosis, and that aponeurosis extends to the extensor pollicis longus tendon. So it has an attachment to that tendon. So you can see here nicely on the coronal and axial images, the normal appearance of the ulnar collateral ligament at the MCP joint. You can see this low signal intensity structure coursing at the joint. And on top of it, or superficial, you can see this thin, low signal intensity structure. And that, of course, is the adductor aponeurosis right there. So we can also assess the ulnar collateral ligament really nicely on ultrasound. And I'm just showing you the positioning here. Abducting the thumb over a small towel is the best way to position the thumb. And you can put your probe in there on a coronal orientation to really nicely see the ligament. And this is the corresponding ultrasound image that you're going to see. So this is the metacarpal MCP joint. You can see the ligament here. It's extending across the joint from the metacarpal head to the base of the proximal phalanx. And when you look really carefully, you can see this very thin hypoechoic structure. In the normal situation, it's very thin and sometimes difficult to see, but if you look carefully, you can see it. So it's superficial, so we know that this is the normal appearance. And we can perform some dynamic maneuvers. So hopefully this video, yes, will play. And if you flex and extend the IP joint of the thumb, you're moving that extensor pollicis longus tendon, and which of course the aponeurosis attaches to that tendon. So you'll be able to see the aponeurosis moving on top of the ligament. So just in the bottom image there, I'm going to show you what you'll see is that very thin aponeurosis moving superficial to the ligament. So if you see that, you know 100% there's not a Stenner's lesion. You can also, in this position, perform stress maneuvers. So you can push the thumb down towards the table in an abduction movement. And when you do that, you can also see or assess for the integrity of the ligament as you examine it in that location. So the ulnar collateral ligament, typically the mechanism of injury is an abduction and extension force or valgus force on the ulnar collateral ligament. We ski out quite a bit up here in Canada. So we see this right on a ski pole. So skiers, thumb, of course, you can have this injury falling and having this force in other mechanisms, but it's typically referred to as a skier's thumb. And so there's either a avulsion of the ulnar collateral ligament, which is typically distal at the MCP joint. And you can see a fracture fragment, which is usually from the base of the phalanx, as you can see in the schematic, or you can have an isolated ligament injury. There's different degrees of injury. So you can have a sprain, a partial tear, a complete tear, which is not displaced, or a complete tear, which is displaced. And that is often leads to a Stenner's lesion. So if you look at the schematic diagram there in C and D, you can see that the ulnar collateral ligament is displaced and the stump is displaced and lies superficial to the adductor aponeurosis. So that's what we're looking for to see if there's a Stenner's lesion. You can have a Stenner's lesion with or without an avulsion fracture. And the location of the avulsion fragment may suggest a Stenner's lesion. So if it's further displaced, that may suggest that there is a Stenner's lesion. On MRI, you can see here this coronal image and corresponding axial image. There's a lot of edema around the MCP joint. And you can also see here that there is a displaced and retracted ulnar collateral ligament, and that the adductor aponeurosis outlined in yellow here is deep to the displaced ligament. So that is consistent with a Stenner's lesion. It's also been referred to, a Stenner's lesion has been referred to as a yo-yo on a string appearance on MRI, where the string is the aponeurosis and the yo-yo is the displaced ligament. So we've been talking about the ulnar collateral ligament, which is really the ulnar collateral ligament proper. But in addition to this ligament, there is also an accessory ulnar collateral ligament that is contiguous with the volar base of the sesamoid bones to the MCP joint. And the proper and accessory ligaments are taught reciprocally in flexion and extension, as you can see here in the schematic. Here we can see the proper collateral ligament here outlined in blue. And you can see the accessory collateral ligament here outlined in purple. And we also have palmar ligaments. And these palmar ligaments are additional ligaments that attach to the sesamoids and are called the metacarpal sesamoid and the sesamoid phalangeal ligaments. So just, there's a little bit more complexity to this anatomy. This is a case of a 31-year-old female volleyball player who was 3 weeks post-injury. We can see here that there is, on this coronal image, that there's a torn and retracted displaced ulnar collateral ligament. And you can see this on both the coronal and on the axial images here. The adductor aponeurosis is deep to the retracted ligament, and this is compatible with a Stenner's lesion. However, there is also an additional non-displaced avulsion fracture at the volar medial base of the proximal phalanx, and this is due to the ulnar sesamoid phalangeal ligament, which is causing an avulsion injury at approximately this location right here. And courtesy to OCAD and Hilary Humans for sharing that case. So the treatment of ulnar collateral ligaments really depends on the severity of the injury. Conservative measures are taken for partial tears or sprains and non-displaced fractures, and surgical treatment is required if there is a complete tear, especially if it is a displaced with a Stenner's lesion, or if there's a large fracture involving the articular surface. So the take-home points for this case are to remember that the adductor aponeurosis has an attachment to the extensor pollicis longus tendon, and that we can use ultrasound techniques to assess that, as I showed you. Remember that a Stenner's lesion is when the ulnar collateral ligament is displaced and lies superficial to the adductor aponeurosis. And you can have a Stenner's lesion with or without an avulsion fracture. And remember that the displacement of the fracture may help to suggest that a Stenner's lesion is present. Remember that the ulnar collateral ligament anatomy is more complicated, and in addition to the proper collateral ligament, there's also an accessory collateral ligament and palmar ligaments, just to be aware to look for additional injuries. So thank you so much. Again, really, thank you for asking me to attend today, and it's really great to see all of you.
Much, Linda. Thank you. So it's my pleasure to introduce Dr. Taciani Cantarelli. She's a practicing musculoskeletal radiologist at HCOR and Teleimagem here in São Paulo, where she trained during her clinical MSK fellowship. She's also a former research fellow at NYU and a member of several radiology societies in Brazil. She has authored and co-authored articles on the MSK field, and she's a very active MSK educator, lecturing in several Brazilian radiology meetings. Please, Taciani, take it away.
Thank you, Aline. Okay. So hello, everyone. It's a pleasure to speak with you guys today. Thanks for the introduction, Aline. So let's start the case. So my case is about a 16-year-old boy suffering right shoulder pain for weeks. He's a soccer player in the highest juvenile league. The patient related the pain to his training. He's a goalie, right hand dominant, and he also referred repeat episodes of falling on the shoulder during his training, which is habitual. The medical order question is lap injury, and firstly he performed an MRI. So let's check the image. So here we have an MRI image in the coronal oblique plane. On the left, there is a T1 weight image, and on the right, the T2 weight fat suppressed image. This image shows bone marrow signal abnormality at the lateral border of the scapular body extending to the neck with an overt periosteal reaction associated. More MRI image now at the sagittal plane. On the left, there is a proton density weight sequence, and on the right, there is a T2 weight fat suppressed sequence. They show the same finds, features, the bone marrow signal abnormality and solid periosteal reaction along the lateral border of the scapular. These finds are more prominent at the posterior and inferior aspects of the lesion. Now we have a proton density weight fat suppressed image at the axial plane. And one more time, they show the same image finds of bone marrow signal abnormality and solid periosteal reaction at the lateral border of the scapular body. The periosteal reaction is more prominent at the posterior aspect of the lesion and close to the teres minor muscle belly. So considering the differential diagnosis for these lesions, what are the next steps? Just remember that the top two will need a biopsy to confirm the diagnosis. So our next step we decided was to follow a multimodality approach. So this way, 2 weeks later, the patient underwent a CT scan to evaluate the lesion. So this follow-up CT scan after 2 weeks shows a lesion with solid periosteal reaction along the lateral border of the scapular body. Coronal oblique reformat image reveals a linear lucence through the lateral aspect of the scapular body consistent with a healing fracture. These are the 3D bone models of that CT. The 3D reformat CT scans image provide a clearer vision of the incomplete fracture line at the lateral border of the scapular in a healing phase. And for the last, the X-ray, the follow-up X-rays weeks later, show the incomplete fracture line along the lateral border of the scapular below the level of the infraglandular tubercle with some periosteal reaction. These image features are also consistent with a healing fracture. So about this case, the final diagnosis was a scapular stress fracture. So fractures of the scapular is uncommon and usually related to high energy trauma and often associated with other osseous and soft tissues injuries in the chest. But stress fractures of the scapular are even more rare. So those kinds of injuries have been described in the coracoid, the scapular spine, the acromion, and the body of the scapula, like in this case. However, just few cases of stress fracture of the lateral border of the scapular has been reported in the literature. But despite being described in baseball pitchers, there are some similarities in pitchers and goalie sports activities related to the throwing movement, like we can see in these pictures. At these locations, it can be caused by repetitive stress in the area of teres minor attachment. And electromyographic studies have shown that the posterior rotator cuff muscles fire maximally in the follow-through phase of pitching. There are some few case reports like this one of a 28-year-old professional baseball player with similar finds. X-rays and MRI shown the same finds of the incomplete fracture line at the same location at the lateral border of the scapular with bone marrow edema on MRI. Another case in a 17-year-old high school football player where the injury mimicked neoplastic lesion, more aggressive lesion, and stress fractures and neoplastic lesions may sometimes appear similar on radiographs, especially during the healing phase of a fracture due to the periosteal reaction. And it's important to remember that histological specimens of healing stress fractures may be confounded as bone tumors. So this way, a multimodality approach is important in order to avoid false positive bone biopsies. This is a companion case of another patient at our facility. These are MRI images of a 23-year-old athlete, also a soccer player, with the same finds of bone marrow edema and periosteal reaction, and again, same location at the lateral aspect of the scapular body, more prominent, and the posterior aspect. In this particular case, a small fracture line could be seen very clear at the last image corroborating the diagnosis of stress fracture. About the treatment, the traditional proven treatment for stress fractures include rest from the activity until the symptoms have resolved, followed by gradual return to the activity. Usually, the athlete can perform other activities with that extremity that do not stress the affected bone. And this is the follow-up 2 years late of the patient, showing the healing fracture with chronic cortical periosteal thickening without bone marrow edema or periostitis. Although they are rare, stress fractures of the scapula typically heal with no surgical intervention, as in this case. The patient still continued with his soccer activities and regular training. As said before, these injuries can mimic more aggressive lesions such as malignancies, and we could include in the differential human sarcoma and lymphoma, and also infections. So we need to be aware of this particular kind of stress injuries to avoid bone biopsies, unnecessary bone biopsies. So for the last, the proper early recognition of the pathologic process of scapular stress fractures, despite its unusual locations, enables appropriate treatment without unnecessary invasive procedures such as biopsies. It should be considered in patients involved in overhead work and also in athletes who complain of shoulder pain. So that's it. Thank you. Thank you for the audience.
Thank you, Tatianne.
Beautiful case, Tatianne.
Thank you.
Okay, now it's my pleasure to introduce Dr. Jan Fritz, who is a full-time musculoskeletal radiologist, associate professor, and the division chief of musculoskeletal radiology at the NYU Grossman School of Medicine in New York City. His research and practice focus on the development and clinical integration of novel and rapid musculoskeletal MRI techniques, metal artifact reduction MRI, MR neurography, interventional MR imaging, and machine learning techniques. He has authored over 200 peer-reviewed scientific articles, reviews, and book chapters, and lectured at many international and international meetings, but none as illustrious as OCAD case presentation series, I'm sure. He serves on the editorial boards of Skeletal Radiology, Investigative Radiology, Current Radiology Reports, and PLOS ONE. Okay. Go ahead, Jan.
Thank you very much, Hillary. Thank you very much for the invite. It's a pleasure to be here. Is that the right screen, by the way? You see my screen?
Yes.
Okay. Yes, so thank you very much. Yes, so this is a special invite. OCAD is wonderful, has been a great source of peer learning since many years, and the case conference initiative is certainly fantastic. Okay, so here are my disclosures. None are really relevant to the case that I'm showing today. Okay, so we have a 20-year-old man presenting with 3 to 4 months of medial foot pain and ankle pain. The pain occurred gradually, hurts while standing during work at an ice cream shop, no trauma history. At maximum, the pain is 6 to 7/10 and 4 to 10 when walking, interestingly. Never had an injury to the foot. There is no numbness, tingling, or any other symptoms. He is he does recreational athletic activities, nothing major, but he goes jogging, running, ellipticals, treadmill, and works out. He has no family history of or medical or surgical history. So this is the physical exam that was performed by a foot and ankle orthopedic surgeon. So overall, healthy appearing man. On the skin surface, no swelling, no ecchymoses. He showed tenderness to palpation over the medial and lateral midfoot. He had a full active range of motion. He had full strength with plantar flexion, dorsiflexion, inversion, eversion, but it was painful at times. He had intact sensations. He had a negative talar compression test, able to stand on toes and heels, although he admitted to some pain. Interestingly, he had increased midfoot pronation during gait and a weakened push-off. So let's keep that in mind. He had otherwise negative findings of neuropathies. So the orthopedic surgeon suspected perineal tendinopathy or tendinitis, but wasn't sure what this is about, and ordered radiographic series, lab workup, and then to reconvene and discuss the differential diagnosis. So this is where radiology got involved. So we got a series of radiographs, and we're focusing on the midfoot, which is normal. so no findings were seen, and I think that held true during the course of the case as well. I'm focusing here on the cuboid because this is where the MRI findings will be, but you can see here that the cuboid looks pretty normal. There is possibly a suggestion of osteopenia there. However, I'm not sure. I'm biased because I know the case. I'm not sure there's superimposition of the cuneiform bones, certainly, and so it's difficult to visualize, but cortically, everything seems to be intact. So here's the MRI. This was done at a 1.5 T scanner, and a normal sports ankle series with T2 FETs at T1 PDs and mostly fluid-sensitive pulse sequences. And we can see here at the cuboid, there's a focal edema pattern, which is rather interesting. The cortex is intact, the joint space is intact, there's lack of synovitis, there's no joint effusion, and the underlying peroneus longus tendon seems to be intact. So it's one focal area of bone marrow edema pattern. Interestingly, on the T1 weighted images, there is some hypointensity, but on the PD weighted images, there is not. And this is just different planes, coronal and axial planes here, that shows that the edema pattern, interestingly, is right here underneath the peroneus longus tendon. So that's something to keep in mind. So of course, a good way to start is to talk about bone marrow edema pattern differentials in the foot. And so this is a seemingly comprehensive list, but of course, presenting this case, maybe the diagnosis is not readily included or somewhere in there hidden. But for the sake of this, of the discussion, let's quickly run through the differential diagnosis and see where we have a suspicion that this could fit into the case. So the patient denied trauma, right? But of course, traumatic bone marrow edema pattern, subchondral fractures, stress reactions, that is a common thing. And so here is a typical traumatic bone marrow edema pattern. You can see the subchondral lines here. And so here there's some cortical disruption. There's some of the cortex being displaced. So, and there is more T1 hypointensity on that image. Here is another one, similar case. There's synovitis, there's surrounding bone marrow, soft tissue edema pattern. The bone marrow is more irregular when it's contusive. So this is different from our case, right? So the history fits, the MRI appearance is not typical for traumatic contusion or fracture. Of course, infection is always very important, but there was no skin defect, so there's no direct communication, which is usually the case in feet. And also the MRI appearance was not typical for osteomyelitis, right? So we like a lot more T1 darkness. You have the penumbra sign, the confluent T1 hypointensity, like in this case, where you can see there is a skin defect here, and then by direct extension, there is osteomyelitis. But there's usually a lot more soft tissue edema pattern. Usually people have a history of diabetes, vascular disease, so that doesn't really fit. Now, inflammatory, he's in the right age range, right? He's 20 years old. So let's keep that in mind. However, there was no history of an inflammatory arthropathy. And also, this was the only site that hurt. Now, CNO is more in younger people. However, the surgeon did order labs, and all labs for inflammatory markers came back negative. But let's keep that in mind because we may be coming back to that. This may be implicated in the etiology of this specific bone marrow edema pattern. Now, mechanically, that is of course always a category. We know he's active. He does recreational sports, so there could be some sort of mechanical overload. But he denies an injury, right? It became gradually so on. But of course. Degenerative arthrosis is common in the calcaneal cuboid joint, and if you have that here with a small subchondral cyst, then this can look similar. However, he's young and he has full cartilage and no subchondral lesions, so this is less of a consideration. Now, what about neoplastic, right? Of course, this is something to be aware of, and we're very careful about that. And we had this hue of hypointense T1 signal, which makes us a little bit nervous. However, bone tumors in the cuboid are extremely rare, right? So let's keep that in mind. Now, avascular necrosis, Charcot foot with neuropathy. Well, avascular necrosis, he had no history of anything like sickle cell disease or osteoporosis or anything that would predispose him, but it's an option. So here's a case of Charcot. right? So this doesn't fit either. Yes, you can get isolated bone marrow edema, but usually you have a very complex midfoot degeneration with all the fragmentations when it advances. So this doesn't fit here either, right? So what about metabolic osteoporosis secondary? This was actually checked later, and he had normal calcium metabolism, phosphate metabolism. So there was no problem there either. So that couldn't serve as an explanation either. And then we have the famous bone marrow edema syndrome, which of course is so this is basically the category that's left if nothing else applies, but you definitely have a bone marrow edema pattern there, and we don't know, but we're not there yet. So we don't give up yet and categorize the patient as a bone marrow edema syndrome, right? So, so let's see. So inflammatory arthropathy is something to consider. He's in the right age range. Enthesitis could be an option. Of course, insertional tendinopathy / tendinopathy. And then the neoplasm, let's keep that in mind. We have to be careful about that, right? Let's talk about the anatomy of the peroneus longus tendon, right? So for that, I will quickly switch because this video is not running otherwise, but it is running here. So let's see, the peculiar thing, of course, about the peroneus longus tendon is that it takes a lot of twists and turns, and then it turns almost 90 degrees here in the cuboid tunnel, right? And there's certainly some biomechanics that are very interesting and that need to be considered when you have a focal bone marrow edema pattern right here where the peroneus longus tendon turns into the cuboid tunnel, right? And so let's take another look on how this peroneus tendon actually runs along the lateral foot and how it turns under the plantar surface of the foot. And so we're tracing here the peroneus longus tendon on a 3D scan. And you can see here how the peroneus longus tendon is unfolded. So this is called curved planar reformation. So you can use that to unfold curved structures like the peroneus longus tendon to actually see it in one plane. And we can see here that there is like this peculiar turn here, right? So this is a magic angle effect. But this, you can see it here, how it turns into that cuboid tunnel. And so it has long been suspected that this is something anatomically special and that something with these focal subtendinous edema patterns is associated with that. So let's switch back to our presentation and see what this is all about. By the way, if you like the 3D scans, we recently published a seminar series about the state of the art of 3D MRI. And there's one article in there about 3D MRI of the ankle that explains on how you acquire these 3D scans and how you would make these unfolded 3D scans, just in case you're interested. Okay, so what about insertional peroneus tendinopathy? So insertional doesn't fit because the insertion is actually medially, right? But that is important because the patient actually described medial ankle pain, medial midfoot pain, interestingly, but the bone marrow edema pattern was laterally under that tunnel, right? And so here we can see that insertional tendinopathy doesn't fit. Also, I didn't show it, but the insertion was okay, but it probably has something to do with the peroneus tendon here, right? So here's an interesting biomechanical aspect of what the peroneus longus tendon actually does. And so the peroneus longus tendon is important for gait and stabilization of the midfoot when we walk. And so what it does is, in addition to plantar flexion of the first ray, it everts the cuboid and locks the lateral column of the foot. And that's critical for us to actually walk and propulse, right? So that's something to keep in mind. So if you have dysfunction here in this arch, right, this will alter the gait. And remember that the orthopedic surgeon described that. He said he had increased pronation and he had a weak push-off. So he already saw that there was some gait abnormality, which now corresponds to peroneus longus dysfunction, right? Although the peroneus longus tendon itself was actually normal, right? However, we see the subtendinous edema pattern. And so I think that's where we're going with this case. So what happens? The peroneus longus tendon contracts, dorsiflex, and everts the cuboid, locks the lateral column. That permits supination when you do the push-off, and that is effective propulsion. Now, if that locking mechanism doesn't work anymore, that's critically important because the peroneus longus tendon itself cannot provide the strength for gait and the biomechanics without that locking mechanism. And if you have a dysfunction of this calcaneo-cuboid locking mechanism, you get almost exactly, or at least in part, what we saw in our patients. So there's peroneus longus dysfunction and weakness, which is the underlying problem. So he has a midfoot pronation and he has a weak push-off. And that's exactly what this patient had. And so it actually has been described very sporadically in the literature, and it has been called a cuboid pulley lesion. It has also been called by Dr. Morrison from Jefferson a subtendinous edema pattern. But this is a description of what I think is what we're seeing here. So they described this focal edema pattern at the cuboid just subjacent to the tendinous course. And interestingly here, they did a sub-analysis of associated symptoms or associated findings, and they found a high degree of peroneal tendinopathy or tenosynovitis, which you can see here. There's fluid in the tendon sheath here. But remember, our case did not have that. They also found an interesting association here with the inflammatory arthropathies, right? So this is why probably the orthopedic surgeons was aware of that and started testing for inflammatory arthropathy, but the patient is also 20 and in a good range to do that. Now, it has also been described by a second paper from Dr. Saifuddin from England. They also found 4 cases where they had this peculiar bone marrow edema pattern in the cuboid. And they also found almost exclusively peroneus longus tendinopathy there. But also they saw some patients that had erosions, which can be seen here. So there might be a spectrum of this dysfunction, certainly irritating the cuboid and then eventually causing erosions. They made the point in their case series that this is maybe considered a pseudotumor, but should not be considered a mass. So remember that we had neoplasm in our differential, but this gives us some peace of mind that this may actually not be a neoplasm. Also, you know, we don't really see an underlying mass. There's no lytic or extraosseous components. Now, what about the mechanisms on how this is created? So, of course, it's not totally understood, but we know that in the cuboid tunnel, the peroneus longus tendon moves between plantar flexion and dorsiflexion and is held in place by the long plantar ligament, right? And if you have dysfunction here, there is some movement physiologically, and if you have dysfunction, you certainly get more pressure on there, but maybe there's also altered movement between dorsiflexion and plantar flexion. So that could be a mechanism, right? So mechanical pressure overload, that's not unheard of. That happens at other locations as well. However, there's a second theory that this could be a functional enthesopathy, actually. And so this could be inflammatory, but also mechanical, but it's not necessarily a pressure syndrome. And so here's an interesting paper from the anatomy literature that categorizes the cuboid tunnel as a functional enthesitis. Okay, and so what that means is that there's fibrocartilage, and so although we don't see this with MRI, there's a layer of fibrocartilage that's supporting the gliding of the tendon and the movement between dorsiflexion and plantar flexion. And so this is certainly an area where if you have an inflammatory enthesitis, where a bone marrow edema pattern, where this could be a site where the inflammation occurs. So that is interesting. So this is a second theory, right? So we don't know yet, but this is interesting. There's not many cases to go around, so it's probably tough to have a large cohort to really find out what's happening there. Now, the other question is this associated with symptoms, right? So interestingly, the AJR article found that the cuboid pulley lesion, which is the bone marrow edema pattern, is likely a subclinical MRI feature. They did not feel that their patients were point tender there. However, our patient upon palpation was point tender there, right? But also Dr. Morrison in his paper suggested that there's no significant association between the subtendinous bone marrow edema pattern in the cuboid and the lateral ankle syndrome. So it's interesting that most patients actually had medial pain in his study, and that they concluded that the subtendinous edema patterns play a role in medial ankle and midfoot pain, but not necessarily in the lateral ankle pain. And so our patient complained and presented with medial ankle pain, but there was tenderness to palpation over the cuboid. So what's the final diagnosis? So the final diagnosis we derived is a subtendinous cuboid edema pattern, also known as cuboid Pulley lesion, due to peroneal longus dysfunction, not necessarily tendinitis or tendinopathy, but probably weakening and impaired calcaneo-cuboid locking mechanism. And so the treatment is physical therapy, strengthening of the peroneal longus muscle tendon unit to get that mechanism back and to stabilize the gait and hopefully get this locking mechanism back. Now, when you follow Twitter, which I hope everyone does, this actually came up. So we posted this case before because it was so peculiar, and Dr. Morrison also posted a case here at the calcaneus, but similar with a prominent peroneal tubercle, also this subtendinous bone marrow edema pattern. So it seems like subtendinous bone marrow edema pattern is an entity. It's not common, but when you have it, it's usually associated with a subtendinous location, but may actually have biomechanical implications, which was a nice correlation in our case. So follow us on Twitter if you want. We publish cases on a weekly basis from NYU, but also my Twitter account, and there's great discussions going on, and everybody chips in and contributes fun facts and educational experience. Thank you very much.
Thank you very much. Beautiful case and explanation. Thank you. Well, I see a question here. It's from you, Hillary?
Yes.
Okay.
Yes. Okay, I guess I could ask it. So yeah, and I actually am not familiar with this term functional enthesitis, though I frequently do see reactive edema and even erosive changes deep to the course of tendons. Usually you see tendinosis and or tenosynovitis. And it was my understanding that it was just simply secondary to that, wherever it is in the body. But you mentioned this functional enthesitis, and that's compelling. And while it may be rare in the perineal tunnel, I mean, we see it all over the place. I can think, you know, most notably deep to the first extensor compartment tendons at the wrist. What do you think? This is all functional enthesitis, and we should be checking inflammatory markers, or what? Just chronic mechanical friction and reactive edema?
Yes, exactly. So that's what I learned from this case as well. So a functional enthesis is defined in that anatomy paper not as an insertional enthesis, but an enthesis where basically that serves as a mechanism to support the tendon, but there's no actual tendon attachment there, right? So they say these sites are entheses, but they're not in the classical sense. So that's why they call them functional entheses. And I think I also thought that
that's a little screwy, right?
That's how they defined it. Maybe somebody got promoted with that, you know. But
you know, this may actually be in thesis, because in that case of the cuboid Pulley case that had also flagrant tendinosis and tenosynovitis, it was more extensive, and the marrow edema was deep to the groove. This was really isolated to that plantar tubercle, and there is the insertion of the plantar ligament there. So it may not be such a functional enthesitis as an actual structural enthesitis.
Yes, exactly. So
because there was no tendinosis or tenosynovitis.
Yeah, that was the peculiar thing in our case. So this seems to be in the HAR paper, there were cases that did not have peroneus longus tendinopathy described or tenosynovitis, but most cases have that. And in Dr. Saifuddin's paper, all had it, right? And so I think it's an interesting chicken and egg thing, though, right? So they're suggesting that they're saying this is not reactive to a inflammation of the tendon sheath or the tendon itself or any enthesis. This is actually coming from that enthesis that gets overloaded because your biomechanics are not functioning anymore, right? So they're saying this is actually an enthesiopathic edema. It's not something that comes secondary. This is actually the site of origin, right? Because histologically, they showed, in fact, in the cuboid tunnel, that layer of fibrocartilage with the calcified matrix and the non-calcified matrix. And they say, if it's inflammatory or mechanical, but they actually say this is an enthesitis, which is interesting that it's not reactive to tendinopathy. So I guess this is different angles to view it.
Can you share that paper with me?
Yes.
Thank you.
I have a question to Tatianne. We have seen a few studies use MRI-based synthetic CT in trauma patients. Do you have experience with this sequence, and which scenario do you think it would be useful?
Now we are not currently using the routine, just studies, but I think that CT-like MRI can be added in routine MRI studies with minimal increase in imaging time, and could help in the evaluation of osseous pathologies without the additional CT scans with have radiation. In this particular case, I think it could have been valuable since it's a young athlete. So it can change the diagnosis and follow up since we cannot see in the regular MRI sequence the fracture line. So the CT scan could be avoided in this patient with maybe a CT-like MRI sequence. I think it's useful.
Thank you. Okay, I want to thank you all for tuning in today and see you next month. Thank you.
See you next month. Thank you.
Bye-bye.
Thank you. Bye.
Bye-bye.
You.
One, 3 seconds.